It says a young man with cough, blood stains, wheeze, no weight loss, with widespread bronchial breath sounds and eosinophilia of 25%. What questions will you ask him? So we have a young man that has cough, wheeze, and no weight loss with widespread bronchial breath sounds. So I'd like to know the age of the patient and what does he do for a living, his occupation, and how long has he been in the job, and to ascertain how long he has been exposed to any offending agent. We'd like to know the duration and frequency of the cough and how severe the cough is or how severe the symptoms are. Then the cough, is it productive? If it is productive, what's the quantity? And is there increase in production of sputum? Is there any change in sputum? Does the change in position affect the sputum production? Is there any associated shortness of breath, autopnea, fear in the leg swelling, any fever, history of contact with an index case with cough, night sweats, anorexia? Then we'd like to know whether there is a pleuritic chest pain, chest tightness. Does the cough occur? Is it worse at any time of the day? Is it worse at night or early hours of the morning? Does it get better with use of bronchodilators? Is there any trigger like environmental allergens, dust mites, animal dander? Is there any personal or family history of allergy? Is the patient a known asthmatic? Is he on any drug that will exacerbate the cough or trigger the cough? Any exposure to iodinated contrast agents or radiation therapy? Does the patient smoke? Then the next question says, list 5 differentials. My first differential is paragonomiasis. And this is a parasitic disease that causes subacute to chronic inflammatory lung disease. And it's usually commonly caused by an oriental lung fluke, Paragonimus westermani, which has a complex life cycle involving 2 intermediate hosts. The transmission of the parasites to humans occurs through consumption of raw or undercooked seafood. The symptoms present in the acute phase, that during invasion and migration of the larvae, it presents initially with diarrhea, abdominal pain, and urticaria. Then 1 to 2 weeks later, the patient presents with fever, pleuritic chest pain, cough, and dyspnea. In the chronic phase, that's where the pulmonary manifestations occur, and it includes dry cough, followed by a cough productive of tenacious or rusty or blood-stained sputum, and as well as chest discomfort and wheeze. Investigations we do a complete blood count. We see leukocytosis with eosinophilia. Diagnosis is based on microscopic demonstration of the eggs in the sputum or stool, but these are not present until 2 to 3 months after the infection. Chest X-ray usually shows cavitatory lesions and fibrosis and nodules. Usually, treatment of choice is usually praziquantel, given at a dose of 75 milligrams per kg in 3 divided doses. The next second differential will be allergic bronchopulmonary aspergillosis, which is a fungal infection of the lungs that occurs due to hypersensitivity reaction to antigens of the Aspergillus fumigatus, which is the most common airborne fungus. The organism is commonly found in sputum of healthy individuals, and when the patient is immunocompromised and the patient tends to get the disease, it's commonly presents in the 3rd to 5th decade of life, and usually severe in asthmatics and patients with cystic fibrosis. The clinical features include fever, recurrent wheezing, cough, dyspnea, pleuritic chest pain, hemolysis, and also sputum also have appear like brown mucus plugs, which form a brownish bronchial casts. The diagnosis is usually defined by the following abnormalities. Patient is usually asthmatic, and there's presence of eosinophilia, and positive skin test results for Aspergillus fumigatus. The serum immunoglobulin E level is elevated. Then the minor criteria for diagnosis of allergic bronchopulmonary aspergillosis include positive Aspergillus radio-oligorsobans assay test results and sputum culture. And chest radiograph shows fleeting pulmonary infiltrates, mucoid impaction, and central bronchiectasis. They is usually treated with oral corticosteroids, and the chronic cases with oral atraconazole. Then the third differential is eosinophilic granulomatosis with polyangiitis, which was initially called Chok-Strauss syndrome. It's an autoimmune condition that causes inflammation of small and medium-sized blood vessels in persons with a history of airway allergic hypersensitivity, characterized by three phases: allergic rhinitis and asthma. Asthma is actually a central feature of um, Chok-Strauss, and it occurs in about 97% of patients. There's usually an eosinophilic infiltrative disease, and as well as systemic vasculitis with granulomatous inflammation. It usually presents with initially reconstitutional symptoms like malaria, flu-like symptoms, fever. Then asthma, like we said, is a central feature, and it's usually persistent, warranting the use of steroids. And this use of steroids usually marks other features of the syndrome. There's also paranasal sinusitis, allergic rhinitis, there's cough and hemoptysis, arthralgia, and skin manifestations like purpura and urticaria. So this is a diagram showing the skin rash of Chok-Strauss syndrome. The biopsy of this rash showed the eosinophilic leukocytoplastic angiitis with poorly formed granulomas. And the investigations we do is ANCA and complete blood count, serum immunoglobulin E levels, then bronchial alveolar lavage. Chest X-ray will show pulmonary opacities, usually bilateral, peripheral, and patchy. High-resolution CT show enlargement of peripheral pulmonary arteries with stellate and irregular configuration. And treatment is with glucocorticoids, and persistent steroids. Rituximab can also be used for steroid-resistant cases. Asbestosis is the fourth differential. It's a diffuse interstitial lung disease occurring due to exposure to asbestos dust. And exposure occurs through inhalation of fibers in the air in the working area, or if in the air around the vicinity of factories handling asbestos. The disease always occur after a prolonged exposure, like 20 years or longer, to asbestos. And the patient presents with shortness of breath, persistent wheezing, persistent cough, wheeze, fatigue, and chest tightness. However, the lung function test then shows a restrictive ventilatory defects and reduction in diffusion capacity of carbon monoxide and hypoxemia. Chest CT shows pleural thickening and calcified pleural plaques. And the treatment is with oxygen therapy, nebulized bronchodilators. The patient should quit smoking. Loefflers syndrome is also a differential. It's also known as simple pulmonary eosinophilia. First described as a clinical syndrome characterized by mild respiratory symptoms, peripheral blood eosinophilia, transient migratory pulmonary infiltrates. The patient has an immune hypersensitivity to Ascaris lumbricoides as well as other parasites. The clinical features include low-grade fever, non-productive cough, dyspnea, and occasional hemoptysis. The pulmonary symptoms usually occur during migration of the lungs of the larvae in the.
One more minute.
Sorry.
You have one more minute.
So Loefflers syndrome. Okay, so I'll go to the other These are other parasites that cause that are implicated in eosinophilic pneumonia. We also have drug and toxin-induced pulmonary eosinophilic syndrome, and drugs, antibiotics, and NSAIDs. Those that are based on antibiotics and NSAIDs are normally present with drug and toxin-induced pulmonary eosinophilic syndrome. Some of the drugs implicated are seen in the table. Idiopathic acute eosinophilic pneumonia. There are other differentials like bronchiectasis and tuberculosis, a lot that can present with the above symptoms. So these 5 investigations we would like to carry out in order of priority. To clinch my diagnosis, I would like to do a chest radiograph to show a migratory transient localized intraalveolar pulmonary infiltrate. Then a high resolution CT will also show the classical ground glass opacities. Bronchoalveolar lavage sputum examination can show the larvae or the ova of the parasites. Pulmonary function test will show whether it's an obstructive or restrictive pattern. And complete blood count will show eosinophilia. Others include ANCA, typical ESR, which will be elevated. Some serum IgE levels will also be elevated. What is the diagnosis? The diagnosis would be parasitic-induced eosinophilic pneumonia, which is usually due to Ascaris lumbricoides infection. So how will you treat this patient? Management of pulmonary manifestations in the early phase of Ascaris infection consists of inhaled bronchodilators. Then either you give in form of nebulized bronchodilators, depending on how severe the symptoms are. Then systemic corticosteroids also play a role, but usually the symptom runs its course. Then before you start the steroids, you need to rule out spondyloides infection to avoid hyperinfection syndrome. Antihumins like albendazole also will be used for the intestinal phase. Okay, thank you.
All right, thank you so much, Dr. Alozie, for that beautiful presentation. It was detailed. So now we'll take comments and questions from the participants first, and then let's keep the thanks coming on the chat. Okay, let me make my comments. Okay, so the presentation was beautiful. I want to suggest that that's the explanations to the differential. Maybe we can put them after you've answered the questions. So maybe just answer the questions, list the differentials, and then later you talk about the conditions. Okay, so it was a beautiful presentation. Then as part of the questions to ask, I think maybe you can add rash too, because just like you said, some drugs, maybe like in dress, they could present with eosinophilia. And then, okay, so we can just rearrange it that way. Okay, thank you. So Dr. Lawrence Ade is saying thanks for the presentation. Dr. Makri saying thank you. Dr. Yusuf Rahim says the diagnosis is tropical pulmonary eosinophilia. Then adds to microscopy for ova of parasites. Okay, I also wanted to ask if it would be okay to just say Loefflers syndrome. That's my question.
Okay, yeah, Loefflers symptoms. Oh, sorry.
Okay. Dr. Okute is saying job well done. Dr. Rolly says beautiful presentation. Thank you, Dr. Hugo. Then Dr. Lawrence is adding it's good to quantify the blood also in the history. Okay, so did I add the stool analysis and microscopy? Stool microscopy. Okay, so everyone is applauding you for a beautiful presentation. Okay, so please go ahead. Sir, Dr. Remedios.
Yeah. Okay. You can hear me, right?
Yeah. Yes, I can hear you.
Thank you, Dr. Alozie, for the beautiful presentation. I want to first say that I think the way she did it is not so bad, because it kind of rules out because it will be difficult to do an extensive literature review on all those differentials. she wouldn't have the time to do that, especially for this presentation. So I don't really have an issue with the way she did it. I think it's just her presentation. She didn't have to mention everything. Could have just picked the most important things and said it so that it wouldn't have taken so much time. You get. So it's okay, but just tell us why it's a differential and move on, even despite all the things, the stuff that was there. Okay, so that's what I wanted to say about that one. But I think she missed out something. There's a result. I've seen that question. There was a result before they asked for the final diagnosis, and she missed it out because one would be wondering why she went for Loefflers syndrome at the end of the final diagnosis. There's a result that was given, and she missed it out. So I think she should insert the results. I think it came before the for the final diagnosis.
Yeah, okay. It came before what was the final diagnosis, where they said it showed Ascaris 3 pluses and other indicators are negative. So what is the final?
You missed that one out. Because that's why you chose that diagnosis, right?
Yes.
So you need to insert it, okay, so that people understand why you chose the diagnosis you chose. Okay. So that's what I wanted to point out. But I also wanted to say that the putting some points under the differential diagnosis is okay. It's just that you took too much time going into details. You didn't need to do that. Okay, so then maybe at the end, you now discuss your final diagnosis, but telling us a little bit about differentials is fine. All right, thank you.
Okay, thank you so much, sir. Thank you for the correction. Thank you. Okay, so Dr. Sani, please go ahead.
Thank you very much, Dr. Hugo, for that presentation. Mine just a little contribution. I think it's good to get a clear difference between Loefflers syndrome and tropical pulmonary eosinophilia, because sometimes I don't know whether I was the one that didn't hear it well, but Loefflers syndrome is strictly related to the intestinal elements. Ascaris, some form of hook come at a point, there may be strongyloides. But for tropical pulmonary eosinophilia, it's strictly related to the lymphatic filariasis. So they are two distinct. They can be confusing on the X-ray and clinical finding, but the pathogenesis and even the causative agent are different. They are not the same. Then I also think a line, because the question, when she read the question earlier, it looks like the differential are very mirrored, because there was no any investigation or any something that is giving a differential is superiority over another. That is why probably she opened it up for a lot of possibilities. But I think now at least we understood better that there's an investigation, or probably there's a clue that will likely guide the differentials. Thank you very much.
Well, thank you so much, Dr. Sani, for pointing that out. Very important. Okay, so which one do you think is the diagnosis now?
It's Loefflers syndrome because of the Ascaris.
Okay, thank you so much. So tropical eosinophilia for lymphatic filariasis. Thank you so much. So there are some more comments on the chat. Dr. Pute saying thanks, Rolly. Then Dr. Florence Kalamama is saying good presentation. Since we're thinking of a helminthine course, to what you, as part of what you ask the patient, you can add history of eating uncooked seafoods and vegetables. Thank you so much, Dr. Kalamama. Dr. Christina is saying thank you, Dr. Hugo, for a beautiful presentation. Dr. Adibimpe is saying thanks for the lucid presentation. What's the duration of treatment for the condition? Dr. Hugo, you talked about treatment.
Okay, they said it's self-limiting. It's a self-limiting condition, though I didn't come across any stipulated duration of treatment. What I saw was a self-limiting condition.
Okay, thank you. I saw that, so thank you. Then Dr. Jafar Momodo is adding, stool examination is not useful for diagnosis of pulmonary infection since eggs are generally detected in the stool at least 40 days following pulmonary symptoms. Anthelmintic therapy is generally not administered at the time of pulmonary symptoms since the effectiveness of drugs against larvae in the lungs is uncertain. Okay, that's what they say, self-limiting. If ascaris and strongyloides, no steroids, as this will aggravate it. Okay, so no need for steroids. That's what Momoto is saying. And then Dr. Rita Lako is saying, thank you for the presentation. Thanks so much for the presentation. Okay, I think that's all the comments we have on the chat, and I can't see any other electronic hands raised. So I'll hand over to our teachers. Mark Isabel.
Oh, thank you, Dr. Akela. Thank you, Dr. Alozie. Please, can you go back to the question, please? Okay, the question
Okay, yes,
took
this
them
is
one
what
by
I'm
one.
looking for. Okay. Usually best to just leave the question on a particular slide, then you now subsequently you now be answering them just the way you did. How will you, so that way whoever is going through the material knows how it flowed, you understand? Number 5, how will you treat these patients? Okay. Okay. So how will you treat the patient, please? Can you kindly repeat that, go through that again?
Okay. The treatment of this patient, since it's a self-limiting condition, initially you would like to give an inhaled bronchodilator, either in the form of nebulized salbutamol. I actually did not see a typical case that was treated on online or in the textbook. So it's just given inhaled bronchodilators. Then if the symptoms, if it's needed, you now introduce systemic steroids for severe pneumonitis.
Okay. Actually, for this particular, let's see the question, the beginning of the question. That most time it's good to Dr. Momodu, do you want to say something before I see what I want to say?
Okay, thank you, ma. Yes, ma. I just wanted to point out for pulmonary ascariasis, the treatment is actually symptomatical. And in terms of how the patient will present, if the patient actually, because they're supposed to even do some of all these respiratory secretions or gastric aspirate to actually examine and check for the eggs for the ascariasis. And typically, the management for pulmonary ascariasis is supportive, whereby if the patient is symptomatic, having some of all these wheeze and cough, we can actually alleviate it for the patient with bronchodilators. We typically don't give the antiemetics at this particular time. Then for if there is coexisting strongyloides, you have to still check from the sputum or the stool. You don't want to give the steroids because it can actually worsen the strongyloides and make it an hyperinfection, super hyperinfection that will spread everywhere. Then there's also need for some of them in case for steroids, like she mentioned, the steroids to help if there's no strongyloides and the symptoms are still worsening. Thank you, ma'am.
Oh, thank you. That's why I was asking for the question. As I will always emphasize, once they give you question, the most time there's something they are waiting for. Dr. Lozi, can you project the question, please? You don't have the question at all in this on your slide.
No, but I'll put it before I send.
Because this question, because one thing is that's always advice, answer the question. Don't go and set the question for you. This particular question, the first thing you should mention is actually systemic steroid. There was marked inflammation, really marked inflammation in this patient. After systemic steroid, the next
Sorry,
thing
hello?
really
Hello, Dr. Christopher. Hello?
Yes, sir. Yes.
Dr. Lozi, go to the first, your first slide now. There's a question there. Go to your
I
first
think
slide.
The first
Go to
slide
your
just said.
The question is there now. This is the question now. A young man with cough, blood stain, wheeze, no weight loss, with widespread bronchial breath sounds, and eosinophilic of 25%. So they've given the clinical scenario, and the first question was, what other questions will you ask? Okay, so that's how it came. Then the subsequent questions now came.
So because of MAC inflammation, the first thing really is systemic corticosteroid, then followed by antiemetic for this particular question. That's why sometimes we usually advise, that's why most time advise, personalize this question so that you get your full Semitokpe. You can go ahead.
Good morning, teachers and colleagues. I just wanted to still say that I think in one of the updates I attended, one of the pulmonology teachers actually gave this scenario, and it's exactly like you said, Ma, that you give steroids and antihelmintics.
Okay, so we give steroids and antiemetics.
Yes, Ma. That was when she said.
Thank you. Because that's just what, from the experience, I just, Dr. Remiguta, want to say something?
Yes. So we understand the basic treatment. Okay. So, but our infectious disease people, looking at this question, widespread bronchial breath sounds and this significant eosinophilia, do we still just go mildly and start giving inhaled bronchodilators and maybe not systemic steroids? Is that still the way to go? So I would like our infectious disease specialist to weigh in on this, because that's the essence of this class.
Sir, so can I say something? This question was manned by a respiratory physician, and that was what they wanted to hear.
Okay.
Systemic, and they don't want to say it more because of
I understand.
Yes, that's just what they wanted to hear. You don't want to hear too much grammar. If you are going there, they don't sit with you. So systemic corticosteroid, antiemetic. So, except we just want to discuss the different aspects of how it should go in case ahead. You understand? So that just to avoid confusion. So anyone that sees this type of question, any of the international exam, let it be MRCP, whatever it is, whatever the exam that they are in, you know that when they see this particular scenario, this is what they would do. If you want to add on, cannot add on inhaled or any other thing you want to add on. But the first two things they want to know is systemic antiemetic.
Dr. Mohammed, did you put down your hand? We're waiting for you to talk to now. Hello, Dr. Mohammed. You can go ahead, Dr.
Good morning, teachers and colleagues. Thank you, Dr. Ugo, for the presentation. I have two questions. This is also for the maybe infectious disease and the respiratory specialist. We question about what other questions we would want to ask the patient. I don't know if there are specific things that maybe Dr. Ugo did not mention, that any specific catches in regards to the questions we should be asking, the other questions we should be asking, that they could help furnish us with. And then the second thing is, I don't know, allergic bronchopulmonary aspergillosis was one of the differentials. I didn't know if that is a common cause of hemoptysis. I was inclined to think if aspergillus would cause hemoptysis, it would be rather the invasive aspergillosis or the fungal borders, the aspergilloma. But I don't know if ABPA actually causes hemoptysis. I don't know if you could make clarified for me. Thank you.
Well, APBA causes hemoptysis. Actually, the sputum is brown mucus, as in brown, but it also could be blood stained.
Okay, all right. Thank you.
Any
Yeah,
more
yeah.
comment? Okay, go
So
ahead,
then
sir.
he has two questions. The first one was about specific questions. Well, I don't think she covered all the questions. Even if you look at her differentials, there were some questions that, looking at her differentials that she could have asked in that part that she didn't ask. So, but if you take everything as a whole, she covered most of the questions. So, even when she was discussing the differentials and then the part about questions, I think she covered most of it.
So are you done? Hello, sir.
Yes, I am. Yes, I am. It's Dr.
Okay.
Mohammed that raised his hand initially, but it was locked out. I've admitted him again. I don't know if he still has something to say.
Dr. Mohammed, any more comments? Dr. Dahatu is also in class. Dahatu, any comment?
Good morning, ma.
Good morning.
Sorry. Good morning, colleagues. My comment, I think they've discussed most of the thing, and I wasn't very much concentrating, but I don't know whether she talked about apart from paragonomiasis, whether she talked about the schistosomiasis also. Is another good differential diagnosis. And then, just like it's been mentioned, the treatment is usually symptomatic. So apart from the treatment for the impending organism, the albendazole, and then the other symptomatic treatment also we need to give the patient. Thank you, ma.
Okay, thank you. Thank you so much. I don't know if there are any more comments. We'll move to the next question. Any comment from our teachers? Thank you. Thank you, Dr. Alozie. Thank you, Dr. Ekele. Thank you, everyone, for the contribution. Thank you so much for making this session. Dr. Mobodo, Dr. Sani Mohammed, our Chief Remedios, and Dr. Dahatu. Thank you. We'll move to the next question.
All right, thank you so much, ma. Okay, Dr. Mustafa Mohammed. Are you in class?
Can my slides be seen?
Yes, very clearly.
All right, so good morning, our facilitators and colleagues. So my name is Dr. Joji, and I'll be taking practice question number 7. So the question goes like this: 7A, classify disease based on duration. B, give 2 examples of acute diseases in cardiology, endocrinology, and neurology. C, what is the term used for selection of patients that present to the emergency using their clinical presentation? D, list color codes used in medical emergency. E, what does the red, yellow, green, and black codes mean? F, a 19-year-old type 1 diabetic patient presents with fever and abdominal pain. What color code will you assign him? And list factors on clinical exam that will determine your choice. G, few hours later, the GCS dropped to 4, and the patient was found to have bronchial breath sounds and an elevated random blood sugar of 20 millimole per liter and ketonuria. What code will you assign him, and what is your diagnosis? And finally, H, outline your management plan and try to briefly state what you will do in each step. So for A, classify disease based on duration. So based on duration, diseases can be classified into acute, subacute, and chronic. And acute diseases generally develop abruptly and often last for less than 4 weeks. Subacute diseases are found in the interval or time interval between acute and chronic diseases, and they last between 4 to 8 weeks. And then chronic diseases last for 8 weeks and may actually get worse over time. So B, give 2 examples of acute diseases in cardiology, endocrinology, and neurology. So two examples of cardiology diseases that are acute heart failure and acute myocardial infarction. Then for endocrinology, diabetic ketoacidosis and hyperosmolar hyperglycemic state. And then for neurology, we can think of ischemic stroke and subarachnoid hemorrhage. Then C, what is the term used for selection of patients that present to the emergency using their clinical presentation? And the terminology used for selecting such patients is triaging, which can be simple, which is done at the scene of an accident or mass casualty, and advanced, where specially trained doctors, nurses, and paramedics identify seriously ill or injured patients. Then D, list the color codes that are used in medical emergency. So these are the color codes used: red, yellow, green, black, and occasionally white or gray. So what does the red, yellow, green, and black codes mean? So the red means that the patient needs immediate attention because that patient actually has a critical or life-threatening illness or injury. Whereas the yellow means the patient has a serious illness or injury and needs immediate attention, which means it is not as severe or not as life-threatening as the red color code. Green refers to patients that are less serious or have a less serious illness and is non-life-threatening, and they are generally referred to as the walking wounded. Then black patients are either deceased or they are mortally wounded. So F, a 19-year-old type 1 diabetic patient presents with fever and abdominal pain. What color code will you assign him? And list factors on clinical exam that will determine your choice. So considering this patient, even though the history given was not very extensive for you to assign a color code, but the child is a young adolescent, he has background chronic medical illness of type 1 diabetes, and he presented acutely with fever and abdominal pain. Based on the various triaging system, I would actually give him a color code yellow, and that will be based on both the WHO, IITT, the adult SATs, and if I was to use the ESI, which I'll come and explain later, I would give him a level 2. And the factors that would determine this color code I would give would be the conscious level of the patient, what his GCS would be at the time he presented, then vital signs of his pulse rate, his blood pressure, his oxygen saturation, his random blood sugar at that time, his kidney function test, his respiratory rate and the various patterns, how hydrated he was or not, what his urinalysis showed, and his arterial blood gases. So I think these would be the major factors that will determine what color code would be assigned to this patient. And then G, a few hours later, his Glasgow Coma scale dropped to 4 and is found to have bronchial breath sounds and elevated random blood sugar of 20 and ketonuria. So what code would you now assign to this patient? So I would assign the highest code of red, and the diagnosis would be diabetic ketoacidosis precipitated by likely community-acquired pneumonia. Then briefly to outline management plan for this patient, principles of DKA management would be fluid replacement, insulin therapy, correction of electrolyte imbalance, and to treat precipitants. This is now a medical emergency. So the airway, breathing, and circulation of the patient should be established. Then also consider transferring the patient to a high dependency unit or intensive care units. Then these would be the markers of DKA severity in the patient: a blood ketones of greater than 6, bicarbonate less than 5, venous or arterial pH of less than 7, a low hypokalemia of less than 3.5, low GCS of 12 or less than, with a low oxygen sats of less than 92, and also a high anion gap of greater than 16. So fluid replacement, our aim would be to replace fluid loss in these patients, and they are estimated to have lost about 69 liters, and that should be replaced in the first 24 to 36 hours, half of which should be given the first 8 hours. IV fluids 0.9% normal saline, initially over 30 minutes, then another liter over an hour, then over 2, over 4, then over the next 4 to 6 hours, depending on the hydration status of the patient. And once the random blood sugar is less than 40 millimole per liter, the patient should be switched to 5% dextrose containing fluids. Insulin therapy, preferably fixed rate insulin infusion at 0.1 IU per kg per hour. And the aim would be a drop of 3 millimole per liter per hour in the random blood sugar values, or until capillary ketones are less than 0.6 or bicarbonate is greater than 15. Hourly RBS monitoring should be done until RBS is less than 14, and then dextrose containing fluid should be commenced, and then the insulin dose should be reduced to 0.05 IU per kg per hour. Then finally switch the patient to subcutaneous insulin when he's fully hydrated and is able to eat and drink. And then finally to pre-mix when appropriate. Electrolyte imbalance, majorly potassium is corrected. If it's less than 0.35, 40 millimoles per liter should be given IV fluids. 3.5 to 5, 20 millimole per liter. And then if it's greater than 5, no replacements, but the potassium should be monitored 6 hourly. And precipitants. In this patient, the assumed precipitant is community-acquired pneumonia. So the best antibiotic treatment would be a beta-lactam plus a macrolide. So I could give him amoxicillin clavulanic acid and then with azithromycin, and then frequent biochemical monitoring of hourly random blood sugar, capillary ketones, venous pH, urine output, and electrolyte urea and creatinine should also be monitored. Then to also treat and prevent complications, DVT prophylaxis using subcutaneous enoxaparin, and to watch out for acidosis, maybe bicarbonates may be added if that is the case, and also to prevent hypoglycemia. Patient education should also be part of treatment. Review glycemic control of the patient, discuss his medication adherence once he's stable, and also counsel him on precipitants of diabetic ketoacidosis. It would be important to review the injection techniques of the patient, how he monitors blood glucose, his equipment, and possible uses of technology that might aid him nowadays. Then discuss his access to medication and possible mental health components, and then provide him with contact numbers and websites, and finally refer him to outpatient clinic. And these are the factors that are considered: resolution of DKA, pH of greater than 7.3, bicarbonate greater than 15, and serum ketones less than 0.6. So these were the new hyperglycemia emergency guidance updates of October 2023, and it was a joint consensus between the American Diabetic Association, European Association for the Study of Diabetes, and these other associations. Basically, they decided to give the hyperglycemia cutoff now to be lowered to 200 milligram per DL, which is 11.1 from 250. And the glucose cutoff has been removed for people with a history of diabetes. And metabolic acidosis is now defined as a pH of less than 7.3 or bicarbonate less than 18. Anion gap has also been removed from the main definition, but it may be used where ketone testing is not available. A normal saline with dextrose can be added or should be added to the IV fluids when the glucose is less than 2.250 milligram per DL. For euglycemic DKA, dextrose and normal saline use simultaneously is recommended, and subcutaneous insulin may be used in patients with mild DKA. And basically, some of these updates have been added due to considerations of the use of SGLT2 inhibitors, which are quite widespread now. All right, so new criteria. I just want to briefly talk about triage systems. All right, so triage systems actually began from First World War, and since then their use has become extensive and diversified. And the systems are supposed to be applied to everyone based on the same medical and health criteria, and it can be done at the scene of an event, pre-hospital, on arrival to emergency departments. The WHO defined triaging as a process of categorizing patients according to their need for medical care, irrespective of their order of arrival or other factors, including sex, age, and the other listed. Or a simple definition could just be the process of deciding the order of treatment of patients. So many methods are in current use, but most of them classify patients into these 4 categories: immediate colored red, most weight yellow, least severe green, and prognosis or very poor black. There are other methods of triaging patients, and these consist of instructions, which I've listed here. And then goals of triaging. There are 3 fundamental goals of triaging. The first one is the utilitarianism. And this theory consists that collective welfare should be maximized, and the ability to do good, greatest good for all patients. And it also prioritizes healthcare workers, because saving lives is not the only health metric from this angle. So it's also important in the utilitarianism to consider patients' mental comorbidities, as patients may need reassurance or even sedation when they come to the A&E. Egalitarianism, and this is an ethical theory that values increasing or expressing quality. And it comes in many variants, because impacts on lives on patients can be physical, it can be mental, it can be destruction of property, it can be social, it can also be loss of services. And it aims to support patients who are relatively worse off, such as the young patients, socially disadvantaged, or those who actually queued up first in line. Proceduralism is the third process and is the process of decision making, and it emphasizes impartial and non-discriminatory decisions and transparency about triaging. Deliberation may be done with stakeholders, including socially marginalized groups, and physicians should not make triage decisions about people who they are partial to. So these processes of triaging, actually, each of them has their advantages and disadvantages. These are the list of some of the commonly used triage systems worldwide: the Canadian, the Australian, the Manchester, Emergency Severity Index, which is used in the United States, the Cape Triage and South African triage systems, which are used in South Africa, and they were actually the first triage system available in Africa. And finally, WHO Interagency Integrated Triage Tool. I'll just talk about the most important of them, the Emergency Severity Index. Now, this is the most commonest triage used in the United States, and they emphasize levels more than colors. The levels are 1 to 5, and what they consider are two things. First of all, the patient's clinical presentation, and second, the resources that apply to patients. So patients that come in level 1 require immediate and life-saving interventions, and in these situations, the number of resources are not considered. If patients don't require immediate life-saving attention but are high risk, or the chances of the patient progressing or worsening is there, then the patient can be considered as level 2, which I would feel if I was to use the ESI in my patient, index patient, initially the patient would be at level 2. So, however, if the patients are neither in level 1 or 2, which means they would either be in level 3, 4, or 5, the number of resources would then decide which category they would be in. And the resources that are used or are qualified in these situations are, first of all, people, specialist consultation. A specialist consultation itself is a resource. And then the equipment, any radiological investigation itself is considered a resource, and any lab or IV fluids or IV-IM injections, each of them are considered a resource. The only IV injection or IM injection that is not considered a resource is tetanus toxoid. All the rest are considered. So a patient that is in level 5 would not require any resource and can be seen and discharged out. So this is the ESI system. So this pathway just shows the algorithm of how the ESI system can be applied. South African triage score. So the South Africans actually developed a simple triage score that can be used in low income countries. And basically what they have are emergency factors, very urgent and urgent factors by the side. So what is actually done is that initially an emergency should be looked out for. If a patient presents with signs and symptoms of emergency, it should be taken straight to resuscitation. And then straight after resuscitation, vital signs should be measured again. And then they should calculate what is known as the TEWS, the Triage Early Warning Scoring System. However, if patients do not have any emergency, then very urgent symptoms or signs should be looked out for, and then vital signs measured and the TEWS calculated. If very urgent signs are not available or are not there, then urgent signs should be looked out for. And again, the same pathway should be followed. However, what is important in the South African system is that at each of these stages, a senior healthcare professional's advice should be sought, and its discretion should be sought also to decide whether the patient should be in that category or a lower or a higher level. Then finally, the WHO Interagency Integrated Triage Tool, which was developed in 2019 and applied from then on. And basically, it serves as the basis for identification of those patients who require immediate medical attention and those who can safely wait. And it can be performed at any point of access, and is developed in conjunction with the ICRC and Medicine Sans Frontiers. 3-color system is applied: red, yellow, green. And this is basically a summary of it. Initially, when patients come, they should be screened for any public health illness of concern. If there is any suspicion for that, the patient should be sent to the isolation area, and appropriate personal protective equipment should first be applied before the patient is triaged. Then 3 categories are available: either the red signs, the yellow signs, or the green signs. The red signs are the ones listed. If that is the case and any of them are found out, the patient is then assessed to be a red patient and then should be seen within 10 minutes. If none of those categories are available, all right, if none of those categories are available, then you check for yellow signs. If any of them are there, then the patient is qualified or classified as a yellow patient and should be seen within 2 hours. If none of those signs are there, then you can consider high-risk vital signs, which are listed there. If none are available or none are there, then the patient can be considered as a green patient and it should be seen within 4 hours. However, if the patient comes in or arrives dead, then he's he should be in the black category. Then from there, the ABC of resuscitation and final decisions of where the patient should be either admitted, discharged, or transferred. This is just a summary of the outflow, and it's important to know that in any category that a patient comes in the WHO criteria, he can easily shift to another category. So that was why in my patients, initially, I thought the patient should be in the yellow category, and then which means priority. However, subsequently, the patient deteriorated, and then the patient should then be in the assigned to the red category, which is an emergency category. So there's also a checklist which is important for triage area. And basically the checklist comprises of 3 sections, sections 1, 2, and 3. So this is what the checklist shows. The section 1 talks about the dates, the facility, and the person filling in the form. And then section 2 talks about core supplies which should be available in every single triage. And they span from gloves to watch, thermometer, pulse oximeter. Section 2 consists of additional supplies that ideally should be useful in triages, and they consist of the ECG machine and triage registrar. Section 3 consists of immediate management facilities which should be there for emergencies, such as an oxygen source, masks, basic dressing supplies, glucose, oral glucose monitoring, tourniquet. Now, for each of these, the presence of the supply, its absence, and the reason why it's absent should be documented there. And this form ideally should be filled at least once a day by the triage lead. But this also assumes that there is a dedicated place for triage where signs are shown for patients. Once they come, they know, okay, this is the area that should be used for triaging, and they should be secure, especially considering what happens to healthcare workers now, or at least it should be in view of security staff, and there should be space for a desk chair, for a triage nurse, a patient stretcher, and wheelchair. And that place should only be used for triaging. So these are just lists of field and disaster triages which are used during disaster times: the START, the SALT, the STM, and the SAVE. The most commonest used are the START and SALT triage, and they both use the same color coding system. So these are just brief discussions of the START and the SALT system. And this is summary. So there are various triage systems worldwide. The universal goal is to supply effective and prioritized care to patients while optimizing resource usage and timing. And preparedness and planning are vital for effective triage. These are my references, and thank you.
Wow, thank you so much, Dr. Salihu Joji, for that professorial lecture. It was obviously very beautiful and lucid. So you have a lot of applause already on the group. A lot of participants are applauding you. I won't take their names because of time. Dr. Chris Ade says, excellent presentation. Thanks, Doc. Cuts across several specialties. Dr. Faye, Dr. Sori, Dr. Modo, everyone is applauding your presentation. Thank you so much for that beautiful presentation. Okay, I don't know if anyone has a comment. You can raise your electronic hand. Okay, so it's just applause. Thanks for the beautiful presentation. Dr. Kalama says beautifully done. Okay, so because of time, I'll hand over to our teachers. Margaret Isabel.
Oh, thank you so much. Thank you, Dr. Koji. I hope I got the name well. Dr. Salihu, thank you so much. That was wonderful. Thank you. Very wonderful. So can I thank you? I don't know if Chief Chitu, any of our chiefs in there.
Hello, can you hear me?
Comment. I'll close the class. Chief Remigos, Chief Cookie, Chief Dr. Fatima, the Hatu success. Yeah, any comment? Yes. You can go ahead, sir.
No, I just wanted to commend the presenter. This was very well researched and was beautifully delivered. In fact, for the first time, our class rep was lost for words. She didn't even have one single comment. Normally, she has something to say. So now she didn't have anything to say this time around. So it was actually a beautiful lecture, and I enjoyed it. The only thing is the time took. That's the only downside, but I think he was more interested in lecturing us than answering the question. Okay, so that's the only downside. So this is a very good resource. But I don't know, next time, Dr. Georgie, it was a beautiful presentation, would have loved you to first answer our question, then you now lecture us. But it's okay. Thank you.
Thank you.
Dr. Hatu. Thank you, sir. Dr. Hatu.
Yes, thank you, Ma. Thank you, Dr. George, for the wonderful presentation. Just to add on for the definition of the attributes of
Okay, Dr. Hatu, your voice is a little muffled. It's not so clear.
Maybe he has a device. Maybe the device is using.
Hello?
I think so.
Hello, can you hear
It's
me now?
better, much better.
Yes, much better.
Okay. Thank you. Sorry, to add on for the definition of chronic, acute, and subacute, that one is okay. But I think for it to be more generic, the acute definition is immediate in hours and days. However, then he mentioned the remaining thing he added so that it will be more generic. Then for the subacute, usually in days and weeks, then to add the other duration he mentioned. For the chronic is in months and years, could even be lifelong. And then the definition he mentioned. But by and large, it's a very good discussion. Thank you very much.
Thank you, Dr. Hatu. Thank you.
Sorry, would that refer to the onset? But I just wanted clarification. That would be referring to the onset of each of them.
No, duration.
Oh, okay. All right. Okay.
Yeah.
Thank you.
But I'm wondering if that would not create more. How about terms like hyperacute? Can you bring it into? And then actually, I think that's part of it. So it's important to note that it actually depends on sometimes subspecialty, sometimes a particular disease entity. So those your time frame, they're not cast in stone. So it's important to note that.
Okay, thank you.
You understand? So
yes, sir. Thank
it's
you.
just like you're just making a generic statement. That's fine. But how about terms like hyperacute? Do they have to come into when you're talking about immediate? I'm just wondering. Thank you.
Okay, thank you. I don't know if there are any more comments. It's past 8.
Dr. Hart, is your hand still up? Or
It seems like an old hand.
Hello, ma.
Sorry, it's
Go
an
ahead,
old hand.
Jay.
Let me drop it.
Okay, sorry. I just got carried away with the lecture, actually. I actually wanted to add that if you could add more examples to, there's the question that asked about examples of acute, I think that was the second question. Give examples of acute conditions in cardiology, endo, and if you could just add more examples, maybe like for the endo, myxedema, coma, Addisonian crisis, thyroid storm, and then maybe for the cardiology, maybe like pericardial effusion with tamponade, acute pericarditis. If you could, instead of just listening to, if you could add more to the slides before he sends them.
I completely
and
agree.
then
I will add them.
Okay, and then for the maybe the comments that Sir just like the duration actually depends on the disease and the subspecialty. If you could add that comment to the slide before you send.
Okay. All right.
Because
Thank you. I'll add that.
For disease, the chronic is 6 months then, but for CKD is 3 months. So to actually vary. Thank you so much. Okay, ma. Thank you, ma.
Thank you, Dr. Salihu. Thank you so much. Well, a wonderful presentation. It's quite detailed. I appreciate your time using getting this ready. Dr. Alozie, thank you, our first presenter. Thank you. Both presenters did wonderfully well. Thank you so much. Our class reps, beautiful class reps, Dr. Ekele, Dr. Kalamama, Dr. Temitokwe. Thank you, all our participants. Thank you, all our teachers. Thank you. I appreciate your presence from Chief Cookie, Chief Bansi, Chief Chitu Remigus, Fatima Okopi, Dahatu, Sanda, Success. I think that's all. Ata, Yahaya, we appreciate your presence. Thank you so much. And all the other facilitators in class, I appreciate your presence. Chief Chitu, sir, tomorrow is Saturday. Can just close the class for us. Chief Chitu. Thought I cited him. Yes, in class. Hello, Chief Chitu. Dr. Fatima, both of you are working together. Want to comment on tomorrow's class? Is she still in class?
Yes, I am.
Okay, go ahead.
All right. Many thanks to both presenters. You did very well. So there will be dissertation presentation tomorrow, and please, we encourage all participants to come and participate as early as 7 a.m. Though we don't even close the class at 7, we allow you to enter whenever you are in. Please endeavor to attend, because that is the best time that you will ask all questions regarding your book, your dissertation, please. And we'll have a dissertation on, I think, nephrology case and dermatology case. So we are expecting you to participate very well, so that you will definitely find something that will benefit you in one way or the other regarding your own book and others. Yeah, so thank you very much till we meet tomorrow, 7 a.m.
Thank you, everyone. Thank you for the wonderful week. Thanks to all the participants. Thank you. We meet on Monday. We meet tomorrow. Thank you. Have a wonderful day. Bye.